Okay, Dr. Barris, you can stop sharing now. And then after I welcome and Dr. Amit will introduce you, then you can screen share again. Okay.
Yep.
Do you see my presentation?
Yes, it is
Yes.
there on the
Okay,
We
slide.
see
because
the
it was also a similar problem in the prior meeting. I'm using Mac and try to present through Keynote, but whenever I go for full screen, somehow everything goes, my pointer and everything. So I will try to keep in that way. If it's okay with you, then it's okay with me.
It's okay, but if it's in full screen mode, it will be much clearer, I think, for the audience.
Yeah, but if I go to for full screen, then I
The
lose
pointer
I
disappear.
lose the mouse track, so I can't point anything. So it will be not logical. Then
Okay, so
let's
this is
keep it that way, because that will be a problem then.
okay. This is good, but if you can, this is in the right side. This if you can make it disappear, so it will be a little bit bigger. I think it will be good.
Just
Yeah, Dr. Barris, you can actually switch off the format panel on the right side of your screen.
Okay, so Professor Amit, I will start now welcoming the audience. Then I will introduce you.
Yeah.
Okay.
Okay.
Okay. So welcome everyone to the 9th webinar of the comprehensive Neur-Anatomy educational course organized by the Yemeni Neurosurgical Society in collaboration with the World Federation of Neurosurgery, Young Neurosurgery Forum, and the Pakistan Society of Neurosurgery, and Neurosurgery Coach, and Neurosurgical TV. Today we'll have Professor Amit Taba, who will be moderator of today's sessions. Dr. Amit Taba is Professor of Neurosurgery at Kathmandu University, in Kathmandu Medical College Teaching Hospital, and he is Chairman of Neuroscience Frontline Hospital at Kathmandu, and was the Vice President of the Nepali Society of Neurosurgery. Dr. Amit, Professor, how are you?
Good to see you again. Yeah. And thank you for
Good to see
having me here.
It's our honor that we have you, Doctor. So, Dr. Amit, you will start introducing the speakers, please.
Yeah, thank you once again. Yeah, and welcome all of you to the Comprehensive Neur-Anatomical Education Course Module 2, which is jointly hosted by the Yemeni Neurosurgical Society with a lot of other partners internationally. We have very learned speakers today with us. We will be talking on different aspects of brain ventricle and venous drainage system of the brain. To start with, I would like to invite Dr. Veres Kusungyurk, who is an associate professor at Istanbul University, and he will be talking on microscopic anatomy of the brain ventricles. Dr. Veres, please share your screen.
Yeah, Professor Thapa, thank you very much for the introduction. Let me go ahead and start because I don't want to take so much time. So I will be talking on the microsurgical anatomy of the ventricles. I will be staying only on the topic of the anatomy. I won't be sharing any clinical data. So when we speak about the ventricles, we need to understand actually we are going to speak on a couple of different structures. Mainly, it would be lateral ventricle, third ventricle, and fourth ventricle. But we need to remember this is a three-dimensional anatomy. So the lateral ventricle has like a C shape or a horn shape structure with the frontal horn, backwards the body, and it turns around the basal ganglia and atrium and goes into the temporal lobe as the temporal horn. So it's a complex anatomy, and we're gonna review it. First, we need to speak about the lateral ventricle, but frontal horn and the body. So each of these structures have a floor on down, a roof on top, lateral walls, and medial wall. So regarding the lateral ventricle and its frontal horn and the body, the foramen of Monro separates these two structures. I mean the frontal horn and the body. And the corpus callosum, here we see, corpus callosum forms the roof of the both frontal horn and the body of the corpus callosum. On the lateral wall of the lateral ventricle, I mean again the frontal horn and the body, there is caudate nucleus. Anterior to the foramen of Monro, it's the head of caudate nucleus, but the posterior to the foramen of Monro, it is body of the caudate nucleus. On the medial wall, there is septum pellucidum. Actually, the septum pellucidum forms the majority of the medial wall, but just most inferiorly, the medial wall is formed by the fornices. And also more posteriorly, the floor of the body of the lateral ventricle is formed by the thalamus. Let's go see some anatomical specimens. This coronal cut through the ventricles, through the basal ganglia and insula is done anterior to the foramen of Monro. So what we see here is the actual frontal horn of the frontal ventricle. Again, the roof is formed by the corpus callosum. You see these passing fibers here. The medial wall is formed by the septum pellucidum, but just inferiorly, it's actually the fornix forms the medial wall, and laterally, it is the head of caudate nucleus. This is a triangular shape, so frontal horn basically doesn't have any floor, but posterior to the foramen of Monro, we will be having the thalamus. So this is an axial cut passing through the level of the insula, let me say, and we see here the lateral ventricle, mainly anterior to the foramen of Monro, there is the frontal horn, and posterior to the foramen of Monro, it is the body of the lateral ventricle. Let's see again the anatomy. The roof was formed by the corpus callosum, which is removed here. The lateral wall is formed by the caudate nucleus. In more detail, the head of caudate nucleus anterior to the foramen of Monro in the frontal horn, and posterior to the foramen of Monro by the body of the caudate nucleus is the lateral wall of the body of the lateral ventricle. So the floor of the body of the ventricle is formed by the thalamus here, basically beneath the choroid plexus here, and more medially, the floor and the medial wall connects at the fornix. So why this anatomy is important? Because there is also a venous anatomy. I will come to that, but basically, we want to see this anatomy by understanding when we go in an interhemispheric approach. Here, this is the falx, the right frontal lobe is pulled, and we go deeper, see the anterocerebral arteries, then cut the corpus callosum, and then we go inside the lateral ventricle. Now the anatomy becomes important because we need to understand in which ventricle we are. I mean, are we in the left lateral ventricle or right lateral ventricle? We may have navigation nowadays, but still it can be malfunction. Maybe after the CSF drainage, it will be showing false results. Anyways, we need to understand in which lateral ventricle, I mean left or right, we need to understand that. So when we go closer and closer, here we see the foramen of Monro. Anterior to it, we are sure it's for the frontal horn. Posterior to it, this is the body of the corpus callosum. And now are we in the left or in the right ventricle? So actually, we need to understand the venous anatomy, and our north pole, let me say, or north star, let me say, is actually on the east. There is thalamus-striate vein, a very large vein, a consistent vein, which is present in majority of the cases, humans, let me say, because the other veins, which most prominent we will be seeing in the operations, will be a vein coming anterior to posterior in the vertical axis. But actually here, we are in the right ventricle, so this is a anterior caudate vein, but sometimes it is not present, and in some specimens, let's see another one. As you see, there is a thick vein again on the vertical axis, but this time it's actually not a caudate vein, it's an anterior septal vein. So the vertical veins coming anterior to posterior by passing at the edge of the foramen of Monro can either be the caudate vein, anterior caudate vein, or an anterior septal vein. But these will be misleading, so we need to have a more consistent anatomical landmark, which will be the thalamus-striate vein. It's always there, and there is nearly never another vein on the opposite side. I mean, here you won't find any vein here coming on the mid portion of the septum. So this thalamus-striate vein coming from lateral to medial and joining the choroid plexus just posterior to the foramen of Monro will show us that we are on the right side. Let's see another specimen. You see, the thalamus-striate vein collects all the blood from the caudate nucleus and other basal ganglia structures, and it drains it into the, not into the, but at the level of the roof of the third ventricle, which will be coming later. Let me go back again. As I said, we always need to find the thalamus-striate vein, which will be coming from right to lateral to medial. So we understand that we are in the right ventricle. As I said, there will be no vein here. Another less consistent landmark is that this choroidal vein always goes straight in a vertical axis, but a little bit with an angle of going laterally. The pathology may depress it or push it, but it's also helpful instead, I mean, as a conjoint to the thalamus-striate vein, but thalamus-striate vein and this small lateral course of the choroidal vein helps us to find the in which ventricle, I mean, left or right, in which ventricle we are. So let me pass these. As you see, there's another vein collecting blood both from the caudate nucleus and the septal area. So this vertical vein cannot be trusted. We always need to find this large thalamus-striate vein, always on the lateral to the foramen of Monro. So let's see one more time. This is the frontal horn anterior to the foramen of Monro. The lateral wall is formed by the head of caudate nucleus. This is the body of the lateral ventricle, and the floor and the lateral wall is formed by the thalamus, the midline, the septum pellucidum, and just at the inferior level, where the medial wall and the floor of the ventricle meets with each other at the corner, we will find the fornix. So when we go around the thalamus, I mean the ventricle goes around the thalamus first as the atrium and then into the temporal lobe as the temporal horn. As a C shape, the ventricle turns around the thalamus. So first look for the atrium. The atrium is formed, it's a pyramid shape ventricular portion. The anterior wall is basically formed by the thalamus, and we'll see the other walls right away. So this is a coronal cut passing through the atrium. the floor, there will be several prominences, one at the floor and two at the medial wall. So the floor, the prominence at the floor is called as collateral trigon, which is the impression of the collateral sulcus into the ventricle, just like the calcar avis, which is the prominence of the calcarine sulcus into the atrium. And there is a bulb of corpus callosum, which is formed by the fibers passing through the forceps major, fibers passing through the splenium of the corpus callosum, namely the forceps major fibers. So this is a right hemisphere. We see the insula, and medially we see the basal ganglia. Again, this is the frontal horn, the body of the corpus callosum. Just like the choroid plexus turns, the ventricle turns around the thalamus as the body, the atrium, and then the temporal horn. Let's see this area, the medial wall of the atrium, a little bit closer. As I said, the anterior wall of the atrium is formed by the thalamus entirely, and at the floor there is collateral trigon. Medially, there are two bulbs or two prominences. As I said, the inferior one is the prominence formed by the calcarine fissure into the atrium. So it is called calcar avis. And the superior one is formed by the forceps major fibers of the corpus callosum passing through the splenium. And when we go anteriorly, then we see the temporal horn. So maybe we are a little bit more used to temporal horn during the temporal lobe surgery. Basically, in many cases, we open it and go into that and find the hippocampus. So we will be speaking on this anatomy in more detail. This is the right temporal horn. The choroid plexus is removed. So we see here the hippocampus. Just above it, there is the fimbria of the fornix into the temporal horn. The roof of the temporal horn is formed by the optic radiation, and most anterior they are called as the Mayer loop. And anterior to the hippocampus, there is amygdala. The amygdala and the head of hippocampus form or are situated in the uncus. Let's go see from inferior view. As I said, this is the temporal lobe, this is the temporal pole. Mesially, there is uncus. In the uncus, in the anterior segment of the uncus, there is amygdala. We'll see it later. And in the posterior segment of the uncus, there is hippocampus. This is the parahippocampal gyrus. This is the mesencephalon. Between the posterior after the apex, between the posterior segment of the uncus and the mesencephalon, there is optic nerve, chiasm, and then optic tract going into the crural cistern and then ambient cistern. Let's remove the uncus and the parahippocampal gyrus as well as the fusiform gyrus to see the hippocampus into the temporal horn. When we remove the white alveus of the hippocampus, we see these dentate gyrus or dentate gyri in the hippocampus. Then when partially we remove it, then we see the fornix here. At the anterior, there is amygdala. I'm passing these a little bit fast because the topic today is not the mesial temporal area. I just want to express that they are at the medial wall of the temporal horn, these structures. When we remove further those structures, then we see the roof of the temporal horn formed by several layers of the white matter. The most inferior ones are the stria terminalis fibers, the fibers coming from the corpus callosum. They are called as the tapetum fibers. They basically pass through the most posterior part of the body of the corpus callosum, but anterior to the splenium. Just I told before, the fibers passing through the splenium are called as the forceps major fibers, and they form a bulb at the medial wall of the atrium, the bulb of corpus callosum. But the fibers passing a little bit anterior to the splenium, and that part of the corpus callosum is called as the isthmus of the corpus callosum, and the fibers passing through the isthmus are called tapetum. They basically connect the temporal pole of one side with the tapetal fibers. These go and pass through the isthmus and go the temporal pole of the other hemisphere. And there is a gray matter here, you see. This is the amygdala, and this is the tail of the caudate nucleus. The caudate nucleus was forming the lateral wall of the frontal horn and the body of the lateral ventricle, and it turns around the thalamus and forms or courses as the tail of the caudate nucleus at the roof of the temporal horn to connect with the amygdala. So we remove them, the tapetum fibers, the tail of the caudate nucleus, then we see the most upper layer of the white matter fibers at the roof of the temporal horn, which are the optic radiations. So I try to go a little bit fast about the lateral ventricle because we have the third ventricle and also the fourth ventricle. There are lots to say, but I just wanted to keep it short to save time for me and other speakers. So after the lateral ventricle, there is this third ventricle. So this is the left hemisphere, including the basal ganglia, is removed. So we see here the third ventricle and the lateral wall, but I mean the right lateral wall of the third ventricle. This is the foramen of Monro. This is the lateral ventricle, and the midline is formed by the septum pellucidum. And there we see the pons. So there are several structures forming the third ventricle. Let's name them and then look back for the anatomy. So this side is the anterior side, this side is the posterior side, this is superior, and this is inferior. The optic nerve forms the optic chiasm just at the anterior margin of the third ventricle, but forms two recesses here, one above the optic chiasm and one below. The above one is named as the optic recess. The below one is called as the infundibular recess. Just we can remember the infundibulum connects here and it becomes the infundibular recess, and the optic nerve connects here and becomes the optic recess. Above the optic chiasm, there is a thin neural membrane, practically with no function. It's called as lamina terminalis, which we open in many cases in ACOM aneurysms. But superior to it, there is anterior commissure, another commissural fiber, just like the corpus callosum. The anterior commissure is a midline structure we see commonly in the sagittal MRIs, but actually it's a white matter fiber structure connecting the temporal lobes between each other. So basically, the anterior margin of the third ventricle is formed again from superior to inferior by the anterior commissure. the lamina terminalis, the optic recess, optic chiasm, and infundibular recess. The roof of the third ventricle is formed by four layers. The most upper one and the most inferior ones are called as the tela choroidea, which are arachnoid-like structures, which we see here. The mid ones, the second one and third ones, is one of them is a venous structure. The other ones are an arterial structure. We'll see them in more detail, but let me name them here. The venous structures, which we see also here, is the internal cerebral veins, and the arterial structures are middle posterior choroidal arteries. The floor of the ventricle is formed after the infundibular recess. We don't see them here in detail, but there is first the tuber cinerum, and just next to just upper to the basilar artery, there will be mammillary bodies. And just after the mammillary body, there will be aqueductus, which connects the third ventricle with the fourth ventricle. At the posterior wall, there is basically the main structure here is pineal gland. There's two recesses here, one above the pineal gland, which is the suprapineal recess, and there is an inferior recess, which is called as the pineal recess. So these are the margins of the third ventricle, but let's see it in a surgical anatomy. When we want to go to the third ventricle from above, from interhemispheric approach, first we'll go to the lateral ventricle. Let's see this again. We need first to see and understand where the thalamostriate vein is. The thalamostriate vein is always lateral and posterior to the foramen of Monro. So that's why this is the right ventricle. This is the left ventricle. We can't trust the veins coming anterior to posterior, but we can have a little trust to the choroid plexus and this superior choroidal vein, which goes posteriorly, but also a little bit laterally. But again, our north pole, our main anatomical structure here is thalamostriate vein. So then there is two ways of going deeper. The first one is opening the choroidal fissure, which attaches the choroid plexus. We can open it from the fornicial side or from the thalamic side. The Professor Roton always suggested it to open from the fornicial side because the venous drainage of the thalamus can join from this angles. So if we open it from the thalamic side, we can damage those thalamic veins. So to preserve the venous structures and neural structures, he always suggested to open the choroidal fissure from the fornicial side. Also, there are these right fornix and the left fornix. We can go midline, interfornicially. But from an anatomical perspective, let's first see what forms the roof of the third ventricle. That's why we split it back, reflected the both fornices backwards. The first thing we see is the tela choroidea, and then we see the internal cerebral veins, which are the major venous structures draining the basal or deep structures of the cerebrum. So all the thalamostriate veins, caudate veins, septal veins, they all drain into the septal internal cerebral vein, and there is medial posterior choroidal arteries, which also supply the choroid plexus. When we go a little bit deeper, we see these arterial structures better. And then we see again this, as a fourth layer. The first one was tela, the vein, the artery, and the fourth layer is again this arachnoidal layer. And then we open it and go into the third ventricle. From an anatomical perspective, the choroid plexus is removed here. The choroid plexus, we are in the right ventricle. Why? Because this thalamostriate vein is posterior and lateral. So this is the right ventricle, right lateral ventricle. There is septal vein and the superior choroidal vein. We begin to open the choroidal fissure from the fornicial side. We can sometimes cut the septal vein, possibly with no major complications, to expand the foramen of Monro to connect with the choroidal fissure to expand the view. But when we open the choroidal fissure, then we can see the third ventricle. This also, this opening can be obtained by interfornicially, but discussibly, if we go from the transchoroidal vein, there's possibility of damaging or destroying only one fornix, while the contralateral fornix will be saved. But the disadvantage is we'll see we have a view a little bit from a lateral angle. So ipsilateral internal cerebral vein can block partially our views, while interfornicial approach will provide a midline and maybe a more enlarged view. But in the meantime, we may damage both fornices, which would have a big complication on the memory of the patient. Anyways, when we open it, then we see the floor of the third ventricle, the lateral walls, there is hypothalamus. We see the mammillary bodies here. Anterior to it, there is tuber cinerum, and anterior to it, there are two recesses. The inferior one was the infundibular recess, and the superior one was the optic recess. Posteriorly, there are two recesses, pineal recess and suprapineal recess. And this is a little bit closer view of the optic chiasm, optic recess, pineal recess, and this is the lamina terminalis here. Okay, I'm also finished with the third ventricle, and then at last we go for the fourth ventricle. So I will, regarding the fourth ventricle, I will be just speaking about the floor or at the side of the brainstem, because the roof of the ventricles, this side of the ventricle is the anatomy regarding the approaches. So I just didn't want to go into so much detail, but I can just say the fourth ventricle is connected with the third ventricle with the aqueductus, as we all know, and the fourth ventricle lies deep to the cerebellum, where in this right picture we had a cut and removed the right hemisphere of the cerebellum to have a view of the ventricle. And when we remove all the cerebellum, we have a closer view of the fourth ventricle. Here there is quadrigeminal plate, and deep to that goes the aqueductus. These are the cerebellar peduncles. And when we see a little bit into more detail, we have this quadrangular shape floor of the fourth ventricle. Again, these are the cerebellar peduncles, and just beneath them, there are lateral recesses on the both side of the fourth ventricle. From superior to inferior, there are several structures. First, I want to mention about these median sulcus along the fourth ventricle. Maybe, I'm not sure if you see it, but there's some round shape here bilaterally. This is facial colliculus, which also hosts the nucleus of the abducens nerve. They are just above an imaginary line connecting the both lateral recesses. So on the upper half of the floor of the fourth ventricle, the important structure is again the facial colliculus, and at the inferior half of the floor of the ventricles, there's first the vagal trigone here. They are not easily separable, but they are very close to each other. First, there is vagal triangle, and also the area postrema, which is this gray structure here. I also need to mention just lateral to the median sulcus, there are hypoglossal trigone. So there's hypoglossal trigone, vagal trigone, and then the area postrema. As I said, I will leave now for the roof of the, I'm sorry, the floor of the fourth ventricle for surgical approaches. Thank you.
Thank you, Dr. Barris. A very beautiful talk, and you have so much clear in your presentation, and you beautifully covered your journey through the lateral ventricle, third ventricle, and the fourth ventricle. For the sake of time, let's take all the questions at the end, and may I ask you to please unshare your screen. And with this, we will have to invite Dr. Alberto Feletti from Verona. He is an associate professor of neurosurgery in the University of Verona, and he will be talking today on endoscopic anatomy of the brain ventricles. Dr. Alberto, please share your slides. Yeah, you're visible.
Yeah. So thank you to the organizer. Thank you to the moderators for having me. Well, after hearing the amazing presentation about the microsurgical anatomy of the ventricles, of course, my duty is easier to explain and to describe the anatomy from an endoscopic point of view. Some of you might wonder, why should we talk about microscopic anatomy and endoscopic anatomy of the ventricles? After all, the anatomy is always the same, and it is actually, the anatomy doesn't change. But depending on the way we are approaching the ventricles, the perspective on the anatomy does change, as we will see soon. Well, no need to spend time talking about the structure of the ventricular system, as we have already talked about that. But I want to start with this question. We can wonder how many structures are named within the ventricular system. Well, I don't think there is a precise number, but some anatomists guess that there are really a lot of structures that can be identified inside the ventricular system. But the real question for us as neurosurgeons is how many structures we should know for performing a safe endoscopic procedure. This is the main question, and this is the aim of my talk today. I want to mention briefly about the history of the anatomy of the ventricles, and if we talk about the history of the research on the anatomy, we have to mention Andreas Vesalius, one of the giants of the anatomy. He used to work as a professor here close by Verona, actually in Padova, which is my alma mater. And you can see the old anatomical theater, the wood anatomical theater, which is the oldest in the world in Padova. And this is a page of this De Humani Corporis Fabrica. Please know that it was written in the 16th century. And if you look at the details of this drawing of the lateral ventricles, it's amazing how at that time Andreas Vesalius was able to precisely draw the shape, not only the shape actually of the ventricles, which is amazing enough because at that time the anatomy could be studied only on cadavers, and we all know that on cadaverical specimens the brain collapses as well as the ventricles, so guessing the real shape of the ventricles was not easy at that time. But he also drew, as you can see, the choroid plexus exactly as they are. Compare the anatomy from the Roton drawings with these drawings. It's amazing for the time. So nowadays we are able to see this anatomy from inside and in vivo through a small bar hole, which is usually placed in the frontal area of the skull. We can obviously use rigid scopes, but also flexible scopes. And what I'm going to show you today is the anatomy seen from a flexible endoscopy perspective. Why? Because with the flexible endoscope, it's possible to explore virtually every corner of the ventricular system, even the fourth ventricle. So we have a quite good experience in doing this, more than 1,000 procedures. My personal series is about 200 of these procedures. And so I was able to collect many videos and pictures, and we published also many of them. So just a quick look on the journey, neuroendoscopic journey within the ventricular system. This is the endoscope entering through the pilloway, the right lateral ventricle, and this is the choroid plexus. We have seen the choroid plexus already. This is the Monro foramen, and then we can enter the third ventricle. A nice view of the mammillary bodies and the tuber cinereum, and then we can bend the tip of the flexible scope to the posterior part of the third ventricle. This is the adductus of the cerebral aqueduct with the posterior commissure, the habenular commissure. This is the pineal recess between the two commissures, and in selected cases, of course, only if it is clinically relevant, we can navigate through the cerebral aqueduct. This leads us to the fourth ventricle. As we can see here, there is the cerebellum covered by the choroid plexus and the floor, which is at the top of the screen. So this is possible using a flexible scope, which has a diameter of either 3.9 or 2.8 millimeters. But let's have a look on some details about what we can see with an endoscope. Well, the previous presentation already showed a lot of this anatomy, so I will go fast on this. If we want to draw the structures that we see from an endoscopic point of view, of course, we have to draw the lateral parts of the lateral ventricle and the floor of the lateral ventricle, and also the medial part. So let's start with from lateral to medial. So the most lateral structure that we can see is the caudate nucleus, which has this direction, as you can see from the arrow. And then we can go more medial, and more medial we can find the thalamus, which is here. Between the thalamus and the caudate nucleus, there is a sulcus, which is called the thalamus striate sulcus, and within this sulcus lies the thalamus striate vein. We have already seen that the thalamus striate vein points towards the Monro foramen, where it joins usually with the anterior caudate vein, which is not visible in this cadaveric specimen, and also with the septal vein, and they all contribute to form the internal cerebral vein, which runs on the roof of the third ventricle. We know that the thalamus is covered by a thin lamina, which is called the lamina affixa thalami. Actually, this explains the white color of the ependymal layer covering the thalamus compared to the other parts of the ventricle. And in particular, the part of the lamina fixa thalami, which is covering the thalamus striate sulcus, is called the lamina cornea. And this lamina cornea covers the thalamus striate vein. And this is the reason why the thalamus striate vein is very evident when it is close to the Monro foramen, but at the more distal part, it appears opaque because it's actually covered by the lamina cornea. If we move more medially, we can find the choroid plexus, which is also pointing towards the Monro foramen. And again, the vein of the choroid plexus and the tinea, which anchors the choroid plexus to the floor of the lateral ventricle. Moving more medially, we can find the fornix, the body of the fornix, and then the columns of the fornix, which are forming the Monro foramen. And finally, at the midline, we can find the septum pellucidum. So as you can see, the main structures of the lateral ventricle, as we can see with an endoscope, are arranged in a sagittal direction. This is very important because this arrangement helps us in orienting within the lateral ventricle. These are some images taken from Roton showing the anatomy that the previous talk has already shown. And this is the endoscopic perspective. So as you can see here in this video, we are looking at the Monro foramen with the columns of the fornix, and this is the fornix. This is the choroid plexus. This is the septal vein, and this is the thalamus striate vein. So let's move on. As you can see, the thalamus striate vein is covered by the lamina cornea, so it becomes more opaque distally. And we have always to remember that following the choroid plexus, it leads us to the Monro foramen. In this case, the septum pellucidum was disrupted, so we could explore also the contralateral lateral ventricle. This is the choroid plexus going to the atrium of the left lateral ventricle. Let's move to the third ventricle. So if we imagine to draw the third ventricle in a sagittal plane, we can draw it like this. So we can draw the anterior part of the third ventricle and the floor. Then there is the roof, of course. And this is the brainstem, in particular the mesencephalon. And above we have the fornix, of course. And we can localize around the third ventricle some very important structures which are actually visible during endoscopy of the third ventricle. One are the mammillary bodies on the floor of the third ventricle. Another one is the hypophysis. Another one is the pineal gland, which is under the pineal recess, below the pineal recess and the posterior part of the third ventricle. Then we can identify the optic chiasm, which is visible from inside the ventricle, as we will see. This is the adagio interthalamica, and this is the location of the anterior commissure, which is rarely, very rarely seen through a frontal bar hole because of the angle of vision. And here, the posterior commissure is located. The posterior commissure is a posterior limit of the adytum of the cerebral aqueduct. And just above the posterior commissure, we have the habenular commissure. And this is the Monro foramen through which we insert our endoscope. So let's see how the main structures that can be seen during endoscopy of the third ventricle are arranged. Let's start from anterior and moving to posterior part of the third ventricle. So the most anterior and upper structure is the anterior commissure, as we have seen. Just below the anterior commissure, there is the lamina terminalis, which actually lays between the anterior commissure and the optic chiasm. Again, if we move back from the optic chiasm, we can find the infundibulum. And just behind the infundibulum, we can identify the tuber cinereum with a very characteristic gray color. Just behind it, we can see the mammillary bodies that are visible also on this cadaveric specimen. And then we have a large part of the floor of the third ventricle, which we identified as tegmen mesencephaly, the tegmentum of the mesencephalon. And then we will find the additum of the cerebral aqueduct. In this specimen, it is not possible to see because it's covered actually by the posterior commissure. And behind the posterior commissure, we have the abenular commissure. And between some of these structures, we can identify some recesses, like the optic recess, just anterior to the optic chiasm. The infundibulum, of course, it's a recess, and then the pineal recess. So as you can see, most of the structures of the third ventricle, as we can see them from above, so from an endoscopic point of view, are arranged in a transverse direction. Again, these are some images taken from Roton. I will not spend so much time on them. I will move directly to the endoscopic vision of the anatomy of the third ventricle. So here you can see a video of the navigation of the third ventricle, where you can see immediately the two mammillary bodies and the tuber cinereum in front of the mammillary bodies, which is the location of the third ventriculostomy, of course. And in front of the tuber cinereum, we can see the infundibulum. And in front of the infundibulum, there is the optic chiasm, and this is the lamina terminalis. And between the optic chiasm and the lamina terminalis, we could see the optic recess. Now I am moving the scope all the way to the back. This is the tegmen of the mesencephalon, and posteriorly, the additum of the cerebral aqueduct appears. This is the posterior commissure, the abenular commissure, the pineal recess, the suprapineal recess, and we can even see the roof of the third ventricle with also the vision of the internal cerebral vein running on the roof of the third ventricle. So it's a very nice view with a flexible endoscope. I want just to point out your attention on the abenular commissure. It's an interesting story because, of course, it connects the abenular nuclei, which are at both sides, and abenular comes from Latin word abena, which means rains. Actually, the abenular commissure looks like a small rain. So the ancient anatomists, the Latin anatomists, have a really nice fantasy at that time. And starting from the abenular commissure, we can see the striae medullaris thalami, which are actually some fibers, some crests visible on the lateral part of the third ventricle. And inside we have fibers connecting the abenular nuclei with the thalamus. These are some pictures taken at the posterior part of the third ventricle. And this is actually a comparison between the normal anatomy with the anatomy in case of hydrocephalus. As you can see, in case of hydrocephalus, the anatomy is completely different. The normal anatomy of the additum of the cerebral aqueduct is triangular, with a thick posterior commissure and a normal abenular commissure. But look, in case of hydrocephalus, the additus becomes more rounded, and the commissures are very much stretched. I will not spend so much time about this because I think next speaker will talk about this topic. So let's move on. Again, we are inside the third ventricle. I'm showing you this case because we did operate this patient who had a recurrent ependymoma of the fourth ventricle in the prone position. And after the removal, with a microscope, of course, as the tumor was very bleedy, we inserted the flexible endoscope through the Magendie foramen up to the third ventricle, so in a reverse way, just to make sure that no blood clots were inside the third ventricle. So actually we found blood clots and we aspirated these blood clots inside the third ventricle. See, the blood clot is at the roof of the third ventricle, of course, because the patient was in the prone position. But why I'm showing you this case? Because this reverse navigation of the third ventricle allowed us to have a nice, very unusual look on the anterior, upper anterior part of the third ventricle with both Magendie foramen and the anterior commissure, which is almost never seen during an endoscopy from the classical frontal bar hole. And this space between the columns of the fornix and the anterior commissure is called the triangular recess. Let's move to the anatomy of the cerebral aqueduct. The cerebral aqueduct is can be divided in 5 parts. The adytum, the first and the second constriction. Between them, there is an enlargement called the ampulla, and finally the egressus. Let's see this video. This video shows very clearly these parts. So this is the adytum, as we have seen already. And as you can see, there are 2 constrictions, this, and between them, there is an enlargement, which is the ampulla. And actually, if you notice, there are some pulsations of the wall of the cerebral aqueduct. And this confirms that actually the cerebral aqueduct has a compliance to accommodate small, tiny, flexible endoscope. And finally, the egressus of the cerebral aqueduct. We have recently published this paper about morphometric model to try to guess if the navigation of the cerebral aqueduct with the flexible scope is safe or not. We basically draw a triangle including the adytum of the cerebral aqueduct and the posterior commissure, and we draw another triangle inside the first triangle, drawing a line at the posterior part of the cerebral aqueduct. And we notice that in the normal anatomy, the height of the first triangle is 1/3, and this height of this trapezoid is 2/3. But in cases of hydrocephalus, this ratio changes, enlarging widely the cerebral aqueduct. And this was also associated with the risk of having small contusions on the wall of the cerebral aqueduct. So this is, I think, very important because, as you know, when we are navigating the ventricles, we don't have any absolute measure. As if we get closer to a structure, the structure becomes bigger and vice versa. So we need some ratios to have an idea of the size of the structures. Let's move to the fourth ventricle. The previous speaker has shown nicely already the anatomy shown by Roton pictures. I will go fast here. We can divide the floor of the fourth ventricle in 3 parts: the superior or pontine part, the intermediate or junctional part, and the inferior or medullary part. And this part includes the calamus scriptorius, which is a very fascinating area, as we will see. Here you have the median sulcus, and at both sides of the median sulcus, you have 2 crests called the median eminences. And as you can see, these eminences, the median eminences, at some points have some enlargements, like this part. We are talking about the facial colliculi, of course, but also down here we have the two triangles, the hypoglossal triangle, and down here the vagal triangle. And laterally to these median eminences, we can find another sulcus, which is the sulcus limitans. And also here we can find some specialized areas like the inferior and the superior fovea and the locus ceruleus, which is the area of our brain producing norepinephrine. So we can move on here, move to actually the endoscopic vision of this anatomy of the floor of the fourth ventricle. We have described this anatomy many years ago, actually, and the pictures at that time were not so clear as nowadays, but still it was possible to show that with an endoscope it is possible to visualize many of these structures, especially those in the intermediate and in the inferior triangle. You know, the amazing thing of of endoscopy is that during endoscopy you don't deplete the fourth ventricle of CSF. So CSF is still there, and this is very important because the pressure of CSF enlarges the fourth ventricle and preserves the normal anatomy of the fourth ventricle. But during microsurgical approaches, this anatomy is somehow altered by the depletion of CSF. Also, the floor of the fourth ventricle is not a flat surface. It has some sulci, it has some crests, and the privilege of a vision through an endoscope is that the light is not coming from the front, but it's coming tangentially to the floor. And in this way, there is like a interplay between areas of light and areas of shadow. And this contrast of light makes these structures very evident, as we can see even in these old pictures. We can see the facial colliculi very bright because they are hit by the light. We can see the medial sulcus. In many cases, we can see also the triangles, but probably it's better to use the new endoscopes. Nowadays, we have also some endoscope with a chip on the tip, not this case, but the vision is even better with those endoscopes. Here you can see the floor of the fourth ventricle and the facial colliculi here and here, the median sulcus. And if you go closer to the brainstem, very soon you will be able to see other structures like these ones. As you can see here, there are some horizontal crests that will become more evident soon. Here they are, here. Okay, these ones are the acoustic striae. And down here, we have the two triangles. In this video are not so clear, but we can have a very nice vision of the area of the calamus scriptorius, which is quite hidden during microscopic approaches to the posterior fossa, because there is a membrane down here, which is called the membrane of the obex, which obstructs the vision basically during microscopic approaches. And here you can see the Luschka, the right Luschka foramen, and the Magendie foramen is down here. And here we are moving laterally towards the left. There is a nice view of the tinea, which is connecting the choroid plexus to the floor of the fourth ventricle. And this is the choroid plexus going all the way towards the left Luschka foramen. A few words about the roof of the fourth ventricle. These are the anatomical specimens by Roton, but let's have a look on the endoscopic vision. So it's very interesting in this case to compare the normal anatomy, as you can see in this left picture, with the anatomy in case of hydrocephalus. So the normal anatomy shows some peculiarities, like when you are entering the fourth ventricle, you have to remember that the roof is at the down part, the bottom part of the screen. So in this way, you can see here a part, the upper part of the roof, which is the superior medullary velum. Like here, this is the superior medullary velum. And as you can see in the normal anatomy, the superior medullary velum has a convex shape. And laterally, we can find the superior cerebellar pedunculus. If we go deeper in the fourth ventricle, we can see that the nodulus of the cerebellum and the tonsilla of the cerebellum are covered, almost completely covered by the choroid plexus. But if we have a look at the situation in case of hydrocephalus, we can notice that when we enter the fourth ventricle, the superior medullary velum is more flat. It's not convex anymore. And the choroid plexus are not covering completely the nodulus and the tonsilla, which become very, very clear. And here you can see also the picture of a comparison between the normal anatomy and the anatomy in case of hydrocephalus. The inferior medullary velum, which is this part here, doesn't change so much. Another privilege of exploring the fourth ventricle roof with a flexible endoscope is that you can actually see the landmarks for the telovelar approach, which are not so easy to visualize during a microscopic approach because they are covered by the uvula, by the cerebellum. But from inside, you can see very clearly the inferior medullary velum and the tinea, which anchors the choroid plexus to the roof of the fourth ventricle. This is a video showing the normal anatomy of the roof of the fourth ventricle. So let's move on. Here we are entering the fourth ventricle from the cerebral aqueduct, the superior medullary velum, which is convex, the superior cerebellar pedunculus. Here we can see the inferior medullary velum, the nodulus, tonsilla completely covered by the choroid plexus. And then we can move on. We can have a nice look of the Magendie foramen with the tinea connecting the choroid plexus to the floor of the fourth ventricle. And here we can see the pica, the caudal pole of the tonsilla, and this is the opening of the central medullary canal. This is another video of the same set of patients. So let's move on with a video about the anatomy in case of hydrocephalus. As you can see, when you are entering a hydrocephalic fourth ventricle, the superior medullary velum is not convex, is flat. And in this way, you can see much better the fastigium, which is not visible so easily in the normal anatomy. Here you can see the inferior medullary velum, the choroid plexus, the tinea of the choroid plexus, and the tonsilla and the nodulus, which are not covered completely by the choroid plexus. And the lateral recess and the tinea, again, connecting the choroid plexus. As you can see here, the Luschka foramen is obstructed. So this also shows a obstructed Magendie foramen, and this explains the hydrocephalus of this patient. Let's move on to the calamus scriptorius, a very fascinating area, which is difficult to visualize during microsurgical operations, but very easy to be seen during endoscopic procedures. So these are some visions of the calamus scriptorius area. Look at this picture, which shows you the apertura of the opening of the central medullary canal with this bundle of white matter, which is called the the fasciculus. So here you can see the two gracile tuberculi, and it's very interesting to see that the gracile tuberculi have there is like a border between the ependymal side of the gracile tubercle and the subarachnoid part of the gracile tubercle. So it's very clear that here there is ependymal and here there is no ependyma. So this is the border, the real border of the ventricle. And laterally to the opening of the central medullary canal, you can see these reddish-orange areas. This is the area postrema, and we will talk about the area postrema soon. This is a table showing you that it's possible to see with this approach many of the landmarks within the fourth ventricle, especially those in the inferior triangle. But in the superior triangle, of course, the vision is more limited with this kind of approach. Sometimes we use sodium fluorescein injected in a peripheral vein to highlight something that it's not visible. So, of course, the choroid plexus is visible and it takes the fluorescing sodium, but look at these images. With the fluorescing sodium, we can see also the tiny subependymal vascular network. And the difference using fluorescing sodium and using normal light is very evident with this if you compare these pictures. There are some areas where only the choroid plexus is visible using a fluorescing sodium injection, like the posterior part of the third ventricle, but in other areas, the fluorescing sodium highlights some very important and intriguing areas. I'm talking about the circumventricular organs. We know 7 of them. The median eminence, which is placed at the level of the tuber cinerarium. We have always been taught that we can fenestrate the tuber cinerarium without any problem because there is no function there. Actually, there is a function there. There is a circumventricular organ, the median eminence. The pineal gland and the neurohypophysis are also considered circumventricular organs, although they are outside from the ventricles. And then the subfornical organ, up here below the fornix, the subcommissural organ just below the posterior commissure, the organum vasculosum lamina terminalis. Also here we have always heard that there is no function in the lamina terminalis, but actually there is a function. There is an circumventricular organ here. And finally, the area postrema at the calamus scriptorius. And with fluorescing sodium injection, it is actually possible to visualize some of these organs. So let's have a look at this video. This is the lateral ventricle, right? Lateral ventricle. We turn on the fluorescing mode. Of course, we can see the choroid plexus because it has no blood-brain barrier. Here we are at the level of the tuber cinerarium. Nothing can be seen with normal light, but when we turn on the fluorescing mode, you can see the mammillary bodies and the median eminence. And at the level of the lamina terminalis, this, which is the organum vasculosum lamina terminalis, which is not possible to be seen using normal white light. So since we are using this fluorescing sodium mode, we are trying to pay attention to fenestrate those membranes, trying to reduce the damage on these circumventricular organs. Again, if we navigate inside the through the cerebral aqueduct inside the fourth ventricle, we can turn on again the fluorescing mode. Of course, the choroid plexus appears, and also these two leaves departing from the opening of the central medullary canal. These two leaves are the area postrema, which is a very fascinating organ controlling vomit and other functions connected to the digestive system. In this patient, we did a reverse navigation from the fourth to the third ventricle, and we were able to see also the subfornical organ below the fornices. So to conclude, flexible endoscopy and endoscopy in general shows the anatomy from a different perspective compared to microsurgery. We were able to count at least 47 anatomical landmarks during our navigations. And sodium fluorescence allows for the visualization of otherwise invisible structures like the circumventricular organs. And in our experience, endoscopy has proven to be superior to microsurgery to describe some specific areas like the cerebral aqueduct anatomy, the inferior triangle of the fourth ventricle, the subependymal vascular network, and some circumventricular organs. Thank you very much.
Thank you, Alberto, for a beautiful presentation. It was a very masterly talk you gave, and we were actually enlightened by the way your flexible endoscope moves through.
Professor Tapa. I don't know why.
Am I audible now?
Yes, we can hear you, Dr. Amit.
But I cannot see.
Yeah.
I cannot hear anything.
Dr.
Okay,
Alberto,
maybe I will.
Problem maybe in your microphone or something.
I fixed. I fixed. Perfect. Thank you.
It's okay. Okay, so we'll take the questions at the end. And with this, I would like to invite Dr. Imra Seltikisi, who is an associate professor at Gaza University, Faculty of Medicine, Department of Surgical Medical Sciences. Dr. Imra, yeah, you are visible. Please share your slides here. That's it. Thank you.
Yeah, okay. Hello, everyone. Can you hear me? So is there any problem with the speakers?
No, it's
Yes,
your
we can
audible
hear
and
you.
the screen is still visible, yeah.
Yeah, great. So hello, everyone. First of all, hi to everyone from Ankara, Turkey. So there's a thunderstorm out. So if you hear any thunder noises, don't worry. I'm in a safe place. So the thing is, I will talk about the anatomy of the venous drainage of the brain, and that's a long talk, and I don't like long talks. So basically, I will talk about something as I specify on some subjects, and I will not talk about some particular parts. So first 4 slides are a little boring because I don't like too many written slides, but at least we should classify what we will talk on and the basic classification of the venous system. And the venous system is how can we classify it? The cerebral veins, dural venous sinuses, ophthalmic veins, diploic veins, and emissary veins. But in this presentation, I will particularly talk about not too much about the cerebral veins, but I will focus a little on dural venous sinuses because as far as I guessed, previous 2 speakers had to talk about deep cerebral veins, because if you are talking about the ventricular anatomy, then you should talk about some of the deep venous structures. And my guess was true, especially Dr. Barış Küçükürük did a very great presentation showing the importance of the deep cerebral veins and the positioning of the foramen Monro and the ventricles and everything else. So that was good. So we should talk about veins and the deep cortical veins and the deep veins, superficial veins. So what we're talking about, we will start with the superficial veins, then we will go into the deep veins, then we will talk about especially the dural sinuses, and somewhere that I want to talk particularly on somewhere that most of the time we pass very quickly in venous anatomy, which is the cavernous sinus and especially the basilar plexus. For example, in a diagram like that, you see cavernous sinuses shown like that, but it's not correct, and there is no basilar plexus here. But we know there's a drainage in basilar plexus. So one of the boring slides, the superficial, which are the cortical veins, So we all know what the cortical veins are. When we open the dura, those are the veins that we deal with. And also there are some middle cerebral veins, and the most important superficial middle cerebral vein is characterized as the Sylvian vein, and the infracerebral veins, which drains into the superficial cerebral vein and cavernous sinus, superior petrosal sinus, transverse sinus, and this kind of skull base parts. So from now on, I will show some anatomical dissections in which some of them we used in this publication, and some of them we did the dissections for this publication. So here we see the superficial veins, but in this particular dissections, as we see the occipital vein, posterior parietal vein, anterior parietal vein, and other frontal parts, and the Sylvian vein. But the thing is, that doesn't represent the anatomical localization of the veins. Yes, the localization, I mean the topography is right, but first is first, we should understand the superficial veins mostly goes through intraarachnoidal. So when they try to move along into the dural sinuses, they should do something. So what they should do, they should penetrate the arachnoidal membrane. They should be extraarachnoidal. Then they should go into the dural sinuses, as we see here. Look, so inside it is intraarachnoidal, and then the dural that we call the bridging veins most of the time. Drainage is into the dural sinus, but in order to do that, that vein should penetrate the arachnoidal membrane and go extraarachnoidal, and in that way it can perform its drainage into the arachnoidal veins. So the superficial veins from frontal to the posterior, from frontal to the occipital, as you see, the frontal part is a little low on venous drainage. Not low, let's say, but from frontal to the posterior, the calibration of the veins are increasing. And as you see here, especially the anterior parietal vein and posterior parietal vein is far more than posterior, we think, but they are important veins. They are important veins because they are most of the time doing anastomosis with the veins like lateral part of the brain, like trollard, or there's Sylvian vein anastomosis. And the second part is when we want to do an interhemispheric approach from posterior, like I will show you next slides, we should do a surgical planning to calculate the difference between two veins like here, posterior parietal vein and occipital vein, or anterior parietal vein and posterior parietal vein. Because this is important, because if we are planning to do, especially in the interhemispheric approaches, and if we go this much posterior, these veins are, we cannot sacrifice these veins. It will be catastrophic. So in order to do this, surgical planning and to understand the posterior part of the superficial veins are very important for surgical planning. Why this kind of surgical planning? Because let's say we are trying to perform a surgical approach to the pineal region, to the falcotentorial junction, which we will make an interhemispheric approach. The veins, the superficial veins, the cortical veins became one of the most important veins, because when we are doing the approach, as well as I will show in the next slides, there's vein of Gallen's, the straight sinus. Okay, we know where they are. But the thing is, during the planning, we should calculate, we should precise where the bridging veins are, so we will understand where the distance between two drainage veins. That's very important. And then we will go for the deep cerebral veins and dural sinuses. I'm not differentiating deep cerebral veins and dural sinuses because they are all interconnected, especially most of the anterior parts. So here we see again the supraesophageal sinus and the deep cerebral veins. But if we go deeper, let's see here on the bottom right, which is the D section. The first is here we see the vein of Galen, the straight sinus, and the splenium part of corpus callosum. So again, in the midline, we are dealing with in the secondal section, we are dealing with the deep cerebral veins, and especially their branches are very well described in our previous speaker with Barış Küçükürük, which I will not go into the details because we have things to talk. And here we see another anatomical dissection. Again, the same part, which the straight sinus, and the vein of Galen, and the splenium part. So as you see, this confluence here is very anatomically very it have neighboring structures, and the splenium is one of the main landmarks. But the thing is it the only landmark? So here we see, okay, here the approach, interhemispheric approach in the real case, and the left first two top pictures are the anatomical dissections. So let's go deeper. So here we see an interhemispheric approach in which we see the posterior falx, the vein of Galen, and the two posterior cerebral arteries aligning together. And on the right, so this is interhemispheric, but here, this is an endoscopic view, and the approach is completely different. Here is the interhemispheric, and here is the supracerebellar infratemporal approach, and endoscopic view, and we see the vein of Galen and the basal veins, and including the posterior cerebral arteries again aligning together. So this drainage is very important, as you see, both in supracerebellar infratemporal approach and also in interhemispheric approaches. So we are going fast forward because I'm pretty sure it's getting late in every time, and I don't want to talk the same things that previous speakers talk. So the other thing that many people doesn't mention too much, which is the venous system of the skull base. So venous system of the skull base is when we ask people, especially my fellows and observers, most of the time they only mention the cavernous sinus. So cavernous sinus, yeah, we know, and the intercavernous sinus and the basilar plexus are in fact the part of the same drainage system. So which means the cavernous sinus, the basilar plexus, which is behind the clivus. The basilar plexus is the venous plexus behind the clivus. The cavernous system, the basilar plexus, and intercavernous system is in fact all together, connected to each other between the layers. So we should understand, especially from the point of endoscopic skull base, we should understand the importance of this venous drainage, because most of the time, sometimes my young colleagues are consulting me or asking me that they have problem with dealing with the venous bleeding in this region. But the thing is, it's not only cavernous sinus, or it's not only the basilar plexus, they're all interconnected. So what we know about the cavernous sinus, in fact, a potential some void, but not void. It's filled with venous blood, and it's between two dural layers, like a pyramid. The top of the pyramid is one part is going back and one part is going down, and the one of the largest surface is we're facing. during the endoscopic skull-base surgery. So this part is not only a venous system, but also an anatomical landmark, which includes the sixth nerve from the bottom and the third, fourth, and the fifth, sixth nerve from the lateral sides. So it's very important to understand it's not only a venous system, but it's a venous system and it's a venous anatomy. It bleeds when you open, but it's also something you deal with, like a anatomical structure which includes all these anatomical, especially the nerves and the arteries. So let's give an example here what I am saying. So here the video will start very quick, and it's just summary video. We will be looking with the 45 degrees endoscope into the cavernous sinus. So on the lateral side, because we are looking into the cavernous sinus, on the lateral side, I will show you before beginning of the video. On the lateral side, on the right side, there will be the cellular and supracellular part, but we will be focused on the cavernous sinus, and we will see what is the venous bleeding. So here is the cellular supracellular part. Here is the cavernous sinus part, and this will be the ICA. And let's see what's happening. So you see, that's the venous bleeding. So if we're talking about the venous anatomy, the venous drainage of the brain, and we shouldn't miss the skull base venous drainage. Here you see the ICA going like that. And on the wall, let's go back again. On the wall, there will be cranial nerves, you see. Third, fourth. So there's a bleeding. This bleeding is not coming from here. Bleeding is coming from here. This is venous bleeding. So you see, it's bleeding like that. When we apply hemostatic agent, the venous bleeding is more, nearly every time easy to manage. You see again? The cranial nerves. Okay, so, but there's a paper from Pittsburgh group, and they defined the ligaments of the cavernous sinus. And cavernous sinus is a venous system, and there's ligaments are defined it. But in pituitary cases, you cannot see these ligaments as they mention. So these two papers, the medial wall of the cavernous sinus papers, are defining the ligaments, their importance. But let's be honest, during a random pituitary surgery which invades the cavernous sinus, we don't see those ligaments. But where are those ligaments if they are mentioning this in the anatomical study? So it changes according to the nature of the tumor. So you see here a cavernous sinus tumor, which is a vascular tumor, which is a cavernous hemangioma. So now we are dealing with a cavernous angioma in the cavernous sinus, which is the one part of the drainage of the skull base. So what should we do? So the tumor is like that. And hemangioma and the ICA are aligned like that in this particular case. And then when we open the dura, we will see the hemangioma and we will see the pituitary like that. So when we try to resect the hemangioma, what happened in this case? The patient was lying in supine position and the hemangioma was pulsating like hell, and it was getting bigger and bigger and bigger. Then we elevated the back of the patient in a reverse Trendelenburg, and it gets smaller and smaller and smaller. So why I'm saying this? I'm saying this because especially in skull-based cases, the venous anatomy, even though when you know the venous anatomy, the control of the bleeding sometimes becomes problematic. The venous pressure can be high. So what I recommend in every single neurosurgeon here, elevating the back or reverse Trendelenburg position decreases especially the venous bleedings from cavernous sinus and basilar plexus. So here we see that case, the same case. So here we are dissecting, and here you see the ligaments mentioned in that paper. And we are now talking about ligaments in a venous drainage system in which there is ICA and the cranial nerves. So if we are talking about the venous system of the brain and the skull base, cavernous sinus, from my point of view, cavernous sinus is the part that most of the time neurosurgeons are not mentioning, but I mean, we should talk about that. So here we are dissecting, and as I say, the back is elevated, so that's why this tumor is like that, you know, squishy, it's soft, because the venous pressure is low. And we keep dissecting. ICA is here. Look, ICA is here. We kept dissecting, we cut all of them. Most of the time, the worst ligaments are between tumor and the pituitary. Now that's the ICA, that's the pituitary, and here's the cavernous sinus, you see. So, cavernous sinus, venous drainage, pituitary, ICA. So as you see, cavernous sinus is a part of the venous drainage. But here's the thing. For example, if you coagulate or, you know, just destroy the deep cerebral veins, it's most of the time that can happen, some catastrophic events. But if you apply a hemostatic agent into the cavernous sinus, nothing happens, because it's all about the amount of, not only about the amount of blood, but it's also about which part of the brain it drains, the venous drainage it makes. So these are the two papers we published about our cavernous hemangioma resections. And the second thing is, again, so we talked about basilar plexus. Now we are looking to the clivus, anterior part, endoscopically. So this is the basilar artery, as you see. These are the cranial nerves. Here is the sixth. But as you see, there's blue silicon. So what does it mean? Why there's blue silicon here? Because the reality is posterior of the clivus is filled with, from superior to inferior, filled with venous blood. It's fills with too much blood. But do we see it in every single case? So because there's venous drainage here and it's part of the venous system, but do we see it? So in cases like that, which are invasive cases, sorry, these kind of cases, I'll just fast forward a little. So let's see, this is the sella, here is the clivus. So when we remove this bone, what we are expecting in normal conditions, we are expecting, moderate pressure venous bleeding. Because this part of the skull base is being drained a little different than the other parts of the brain. So we are drilling. Yeah, we kept drilling to the clivus. You see there's a little bleeding, but not that much. This is not the expected bleeding. The expected bleeding is too much. And here is the median nerve, by the way. And median nerve is very important in skull base operations, endoscopic ones, because that's how we define where the ICA is ended. So we are opening the dura, and the bleeding is not too much because that's a petroclival meningioma. And the petroclival meningioma means it's petrous and clival. So the tumor already invaded the basilar plexus. That's why we don't see too much bleeding. And what we are doing, we are using ultrasonic dissectors, we are using bipolars We are making the tumor shrink. Let's go a little faster. And here you see the vertebral artery. That, by the way, that vertebral artery is the contralateral one because the tumor pushed it. We keep decompressing the tumor by using the ultrasonic dissector, but you see the venous bleeding is not that much. I do not expect that, because that's an invasive tumor. Like which other one? Like the chordoma. So here we see the pons and the arteries, and this patient did well. So let's go to the other case. But this case, let's talk about this case. This case is epidermoid tumor of the cerebellopontine angle and into the Meckel's cave. So these are the postal views, but this is not an invasive tumor like a meningioma or chordoma. So now we are dealing with the venous drainage of the skull base. What does it mean? So this will be fast forward. Just I will show how it bleeds. And look here. It's bleeding. It's very small, so we should do it fast. And you see here the hemostatic agent field. Now we can work much more comfortably. If we don't do this in the early stages of this surgery, then we will deal with too much bleeding. Now I'm using a little more than the previous case, a little more bipolar coagulation. Then what will we do? We will open, then we will resect. Here, just wait. And this is the basilar artery. We are in the cerebellopontine angle. But in this case is different than the previous case because it's not invading the skull base venous structures. So what I'm trying to say here, there's a lot of talk about the anatomy of the brain and anatomy of the skull and everything else. But as some of you know, I do mostly endoscopic skull-based surgery, and all the speakers before me already talked about, especially the thalamic veins and the deep cerebral veins. That's why I focused on mostly the venous drainage of the skull base, which most of the time doesn't mention, even not in the diagrams, but there is a huge venous drainage in the skull base. So these are intraoperative MRI case series papers, and these are our from last year our orbital endoscopy papers, and these are multi-center papers, both with the North American Skull Base Society and the Turkish Neurosurgery Society, and the cases that I showed you before, and we reached already more than 3,000 cases so far. And next week, probably we will operate our 91st and 92nd chordoma cases. So I hope I am faster because I really hate long speeches. So thank you, everybody, for your kind invitation. That's it. Thank you. So I think
Thank you very much.
Yeah, thank you, Imra, for a very lucid talk, and it was fascinating to see you work through endoscopic routes into the skull-base venous system. A very beautiful work and very well elucidated. Well, this brings to the end of the three great talks which we listened this night, and then let me invite the audience for any question answer. Dr. Ahmed, did you see any questions in the chat box?
I don't see any question in the chat for now, but I have a question for Dr. Alberto Filetti.
Yeah,
Dr.
please go
Alberto,
ahead.
okay. In some cases during endoscopy, the foramen of Monroe will be small or maybe even not very wide, so you can enter by the endoscope to the third ventricle. Do you have any idea or tricks how to identify the size of foramen of Monroe in radiology, or you do that only during surgery?
Yeah, it's a good question. Thank you. So, as you said, sometimes we have atresia of the monroforamina, and there are some cases of mono or biventricular hydrocephalus. So, in those cases, radiology is very helpful. It's very clear from the MRI when the monroforamen is almost totally closed. In those cases, we perform monroplasty and septostomy. In other cases, there is actually not a real atresia, but there is a small monroforamen. So in those cases, I do use both rigid and flexible endoscopes in the ventricles, but if I have to cross the monroforamen, I always prefer the flexible endoscope because the diameter of the flexible scope is very tiny, very small, and I have never had any problem with even with small monroforamina. So as long as you have a flexible scope, you don't have to worry so much in crossing a small foramen of Monro.
Thank you very much.
And in case you have a rigid only, I think it's a good idea to use neuronavigation for a good trajectory in those cases.
If I need to
Well
do
said.
dilatation of the foramen of Monro, do you have any trick or do you have any method to avoid complication or injury
Yeah.
to the fornix or alveolar structure?
Right. So there are some areas which are more risky, and those areas are the posterior part, which is closer to the interior cerebral vein, and the most medial part, which is the border with the columns of the fornix. So in those cases, when I have to do a monroplasty, I pay attention to avoid those areas if possible when I enlarge the monroforamen.
Thank you very much.
In fact, just a word of caution, foramen of Monro is located very near to the genu, the bend of the internal capsule on the lateral side. It is just immediately located to it. So that's one thing which we also should be aware of when we are going through the foramen of Monro. Well, any other questions, Dr. Hamid?
Yeah, I have another question for Dr. Anda. During either microscopic surgery or endoscopic surgery, if we have a cavernous bleed and you have to do inject some hemostatic agent, is there any specific hemostatic agent preferred, and is there a specific angle, especially during microscopic surgery? Do you have some specific angle to
Yeah.
inject
Yeah, very good
to
question.
avoid
That
any
angle
complication?
angle thing is very good question. First I will start with the angle. My surgical nurse always prepares the tip of the hemostatic agent a little angled. So it's not straight, but the tip, only the tip. The second thing is, maybe you're asking, so if we're applying it to the right cavernous, should I apply it from the left nostril? Most of the time, that's the way we do that way. But the thing is, not particularly, because cavernous sinuses are not too far away from the midline. So you can use the same nostril, but what we do is just making a little angle to the tip of the hemostatic agent. And I don't want to give names of the hemostatic agents, but we are using the, what is in the market, not something different. So there are some companies providing these hemostatic agents, but nearly every hemostatic agent we tried and they all worked well. So, you can use anything.
Thank you very much. I'll see if there is anyone of the audience. If I have any question, please, even you can ask directly or ask in the chat.
I have a question to Barış Küçükürük, in fact.
Go ahead, Doctor.
Dr. Küçükürük, maybe you should mention something about the young neurosurgeons, what they should do if something goes wrong, especially with the deep cerebral veins. Let's think like a bleeding started. What they should do? What's your approach? Because most of the time, as I know from my residents, they tend to coagulate directly to the every single bleeding they see. But I think maybe you should mention something about that.
Yes. Yeah. Great question. Thank you. So veins are not like arteries. So there is actually for a vessel, particularly I'm speaking on the arteries, you can either coagulate all of the artery, or you can just put your bipolar next to it, and with a low coagulation, you can make it squeeze. But this won't work with veins due to the absence of the muscular layer. So if you bring your bipolar and make it work around the veins, they will close. And with deep veins, it will be catastrophic. So the best thing, step by step, would be first putting a cottonoid and then wash the excess amount of blood first, and then try to find the exact point of bleeding. And then there are steps you can do. If you are very, very lucky, just a small amount of Surgicel, not fibrillar Surgicel, a regular Surgicel would work. Or you can put some fibrillar Surgicel and take the fibrin glue, the T cell we have in Turkey. But as you know, the nurses mix them with each other. It's two parts, but you can just take the fibrin part and put just one drop or two drops with a dentate needle on top of the fibrillar Surgicel. So again, the first way is just putting a regular Surgicel, but probably it won't work. Second, fibrillar Surgicel, and on top of it, some drop of fibrin. But my way of doing it is I always cut a very small muscle, just around the size of a rice, let me say, very small, just 1 or 2 millimeter, and put it on the hole on the vein, and then put T-cell on it. It always stops. And I also done a couple of times fluorescein video angiography to see if the vein is still working, and it was working. So my way of doing is, again, there is 3 ways, but my way of doing is just put a very small muscle on top of it and put fibrin glue on top of it. So it always works, always. But if you can't find a hole, then some Surgicel may work, but no coagulation, for sure.
Thanks.
Anyone have any questions, please? Someone here in the chat asked Dr. Alberto if you can send him the book of neuroendoscopic surgery. Is that possible?
Yes, I already sent.
Okay, thank you. So I guess there is no more questions here in the chat. Dr. Amit, do you have any comment or any remarks?
Yeah, I actually thoroughly enjoyed the whole talk by Dr. Beres, Dr. Alberto, and Dr. Emra. Well, they beautifully had presented the whole talk about the ventricles and the venous system. And just to add the historical meal to it, it was Herophilus from Greece towards the region of Bosporus. That was in the year 335 BCE, when he first mentioned about the brain ventricle anatomy as well as the venous sinuses. And somehow we are talking on these two issues in the same session. So Herophilus is credited to name the choroid plexus. So this is how the whole history of ventricle and the deep venous system had been so fascinating throughout these years to these neuroscientists. Well, I'm truly appreciate the effort these speakers have put in making the presentation and very clearly and very simply putting in very complicated or complex task of making the anatomy clear to the young neurosurgeons across the world. Thank you, everyone, for putting the things together. And thank you, Dr. Ahmed from the Yemeni Neurosurgical Society for bringing us all together in this platform.
Thank you very much, Dr. Amit, and we are honored by your participation, all Dr. Amit and Dr. Baris and Dr. Alberto and also Dr. Imra. And thank you for our speakers for this fantastic presentations and very clear and comprehensive information. And thank you, Dr. Amit, for this nice moderating of this session and enriching the discussion. And I think by this we can conclude our 10th session. So if there is no any remarks or no any questions, I think we can conclude and close this webinar.
Thank you.
So thank you all
Thank you.
Thank you.
participating.
Thank you very much. Shukran. Assalamu alaikum.
Wa alaikum assalam. Shukran, Dr. So I hope you can join us all in more presentations and more lecture like this. And thank you all. And we can conclude our 10th session. So goodbye.
Thank you all.